coming, and thank you to everyone for joining us today. I'll go around and we'll just quickly introduce everybody, and then we'll kind of jump into things, I suppose, as we're already a little bit late. So I'm Beth. I'm one of the diabetes specialist nurses down in Southampton in the community. If I go round my screen, so Vicky, do you want to introduce yourself?
Hi everybody, yes, I'm Vicky Alabraba. I've recently started at the Eden team at Leicester Diabetes Centre, previously in Liverpool.
Phil?
Yes, I'm Phil Newland-Jones, consultant pharmacist for diabetes and endocrine at Southampton Hospital.
Perfect. Tamsin?
I'm Tamsin Fletcher-Salt and I'm a diabetes specialist nurse at the Royal Stoke University Hospital.
Perfect. And Ines?
So my name is Ines Fonseca. I'm a diabetes and endocrinology pharmacist at Sheffield Teaching Hospitals.
Perfect. And Andrea?
Hi, yeah, I'm Andrea Lake. I'm a diabetes specialist nurse at Addenbrooke's in Cambridge, but currently undertaking an NIHR clinical doctoral research fellowship at UEA.
Yeah, you're superstar clever DSN, aren't you?
Sure about that.
You are. So I think today this is like our second part to what we did at the weekend with the Goggle Docs guys, and obviously they were very keen to talk about all the headlining data and the new drugs and stuff that came out from ADA. And then we obviously had a bit of a discussion in the forum and said that it's a bit of a shame that there wasn't a lot of nurses that go to ADA, and we could only find you, Andrea. And so we wanted to kind of get a little bit more into the sort of other things that were coming out from ADA that are maybe a bit more relevant to clinical practice that we do as nurses and pharmacists sort of day to day, rather than the big stuff that's maybe a little bit far in the future. So hopefully we're going to have a few things to talk about. We've got a little bit of a list, but if anyone has seen anything around on social media or anything that they want to ask us, you're welcome to put any questions on the Facebook page, and then we can ask the guys and have a bit of a discussion. So I think, Tamsin, you've got the first question to ask.
So yeah, this question's for Andrea, and it was regarding the inpatient CGM data that was coming out from ADA.
Yeah, so one of the things that I was a little bit shocked about actually when I was listening to one of the presentations was about the response to COVID and DKA management in the United States, simply because I hadn't considered it. So they had a real shortage of PPI, and I don't think they're alone in that experience. But what that meant is that there was a response where they didn't want to go in and do the hourly glucose testing that was required for fixed rate infusions or sliding scale infusions. So what they actually changed to was subcutaneous treatment for diabetic ketoacidosis. In that. So that was just kind of one thing I wanted to mention. But what the FDA also announced in 2020, which I believe, from what I gathered from what I watched, was in response to COVID, is that they would not object to the use of CGM in the inpatient setting. And again, yeah, my primary interest area is in the inpatient setting. So of course I was drawn to this. And generally, I think as we maybe all would expect, that it was very useful, and it actually really did help care. But what was quite interesting is a lot of the studies, one of the key things I took from it was a lot of the studies had said that the MARD reported was usually around 9%, whereas actually what they found is that it was a bit higher, where they were up at sort of 13%. But they felt that accuracy was good enough for sure, although obviously they would still need to do some finger stick glucose testing. There were other sessions that I listened to though as well, looking at inpatient diabetes management, and for various different systems they used CGM in the inpatient setting, for example with remote monitoring, because again in the setting of COVID they didn't want to be sending healthcare professionals up to those ward areas, and actually they had some really interesting systems where they were using CGM and they had linked it to an app on a tablet which sat at the nurses station so they could watch them live there. But they also linked to people who worked in offices outside of the building who would do consults and glucose reviews. So I think one was they were saying that it seemed to be accurate, but I think there needs to be more work looking into that from what I can gather. But I think also there was some suggestion on how we could use that moving forward, and they said one of the key things with these remote reviews was efficiency, but there was no injection site reviews, no real talks with patients, no foot checks. So I think you could probably argue both ways, maybe.
Yeah, that's cool. Phil, do you have any, because I know you guys and Tamsin, obviously I'm community, I think Vicky's community. So do you inpatient guys have any, and as do you do, I suppose you're inpatient as well, aren't you? Yeah, do you have any views on that? Or
so we, as part of this, we had obviously set up this COVID guideline group at the start with Joe Raymond chairing, and we discussed actually a lot around the use of Libra and CGM to try and reduce the having to go into closed bays or rooms and exposing nurses to aerosols whilst going in, essentially just to do 2-hourly or 1-hourly glucose checks for those on variable rate, for example. And Abbott at the time obviously were approached to provide a load of free sample to the NHS to try and support that program as well. I think there was a lot of concern that it might end up with more confusion than was necessary at the time, because I think there was a lot of redeployed staff in those areas. Certainly in ITU and HTU settings, a lot of those staff were from theatres and were already questionable on the ability to just do blood glucose tests and be up to date with the new machines in that respect. And I think it was, at the time, it was just felt, certainly in our hospital, it was not a priority for us, in considering how much training would have to go in for those staff when they had so many other things to learn at that time. So the timing just wasn't right, because when it was suggested, we certainly had just too many patients and too many redeployed staff having to deal with it. So I think my concerns were nothing about accuracy or nothing about anything else, but more about the ability for staff to utilise it and understand it, and the capability of our diabetes service to train those staff when we had 30, 40 referrals a day for new insulin starts. It was, so I think the practicalities versus the theory behind it were maybe slightly different.
yeah, what do you think, Ines?
I think I would agree. Sorry, Ines. I think I tend to agree. I mean, I was I'm an ex-critical care nurse, and 7-8 years ago we trialed like an ICU kind of CGM, and it just did not work at all. It just wasn't. It just wasn't compatible really for intensive care patients and things like that. And I think I would agree that it's easy to train one person who's got diabetes on using a Libra or a CGM and advising them how to check and and do finger pricks if needed, but trying to do that across the whole of a staff base in the middle of what effectively was an extremely stressful time with very, very sick patients, it wasn't really going to be an option, I think. And getting them actually to do blood glucose monitoring at appropriate times is easier said than done, never mind monitoring a CGM or a flash, basically.
Yeah, no, I agree. It sounds like a lot of labour intensive work in a really stressful time period as it is, like Phil said. What do you think, Ines?
Yeah, so I think similarly to what Tamsin and Phil said, the same situation really happened in Sheffield. Pre-COVID, we're actually still recording blood sugars in a paper card. So that kind of made us move towards electronic recording of blood sugar. So that was a big change anyway, which allowed remote reviews anyway. But definitely we felt that was not the right time for it.
Yeah, no, that makes sense.
I think that one of the things to mention, Beth, as well, is that certainly our ITU and HTU teams will quite often use gases for their glucose levels, just because when you're peripherally shut down, capillary glucose testing isn't necessarily the best format.
Yeah,
it's often a lot lower than maybe your blood glucose levels are. So I think sometimes there's just a concern about the accuracy in those settings. And I know that we did the same trial as Tamsin was on about as well, and we didn't quite find that it was accurate enough at the time, but obviously technology changed. So more than willing to give it a go in the future. It just wasn't the right time in the middle of a COVID pandemic, I think.
Yeah. You going to say something, Andrea?
Yeah. I think you just hit the nail on the head there, Phil, because they were saying that they suspected the increase in the MARD in their real world experience was probably down to acuity of patients. And also one of the things that they did emphasize in the presentations was the need for education. A lot of these places who were doing this already had a trust-wide education system of some sort, so there was already education programs in place. And for those that used it in those sort of dire situations of the COVID pandemic, we were very lucky for the most part, from what I can gather, as point of care glucose testing continued, whereas for them the option was that or nothing. So I guess your risk versus benefit there is slightly different.
Yeah, exactly. Okay, Vicky, have you got a question whilst we're on the inpatient setting?
Yeah, sorry, it helps if I take myself off mute. Yeah, so whilst we're on the inpatient side of things, I understand that there was a session about discussing the proactive use of starting SGLT2 inhibitors and or GLP-1 receptor agonists during an inpatient stay, rather than making the recommendation and then writing to the GP and asking the GP to do this. Is that right?
Yeah, I can start with that. So I actually watched that session. It was quite an interesting debate. And I think it was between a cardiologist that was in favor of initiating these drugs in an inpatient setting versus an endocrinologist or a diabetologist against the initiation. So the cardiologist basically said that it would be helpful to actually address the underutilization of these drugs. If we just start them when, of course, you mentioned patient clinically well, and also allow more time for counseling points. So he did say that the initiation would be potentially safer in an hospitalized patient. Also mentioned that it could allow potentially the titration or adjustments of insulin and diuretic use doses, for example, okay, while still an inpatient. On the other side, we had the diabetologist's point of view, and I think we do tend to be a bit more cautious about it, which definitely said that most patients or participants in the CVOTs, the cardiovascular outcome trials with these drugs, were actually outpatient, in the outpatient setting. We've got a couple of trials done in inpatient, but nothing, no big numbers so far. And it's quite difficult to extrapolate that data and start initiating those drugs in inpatient settings. Also, the risk benefit, the short risk benefit ratio in an hospitalized patient can change dramatically, as we all know, right? A patient can be well one day and then decompensate to deteriorate overnight. So there's always that balance. And I think the discussion ended up with the suggestion of actually approaching outpatient initiation as an MDT. So get the nephrologists, the cardiologists, well, in an ideal world, we all know that.
Yeah, I was going to say, that's quite hard.
Yeah, I can see you smile. I can see you smiling. Yeah. And
even, the GP, get them in as well.
Exactly. And just get these drugs started. But yeah, it was very interesting.
Yeah. What were you going to say, Vicky?
Yeah, I was just going to say, I can probably see it from both sides of the story, really, having been an inpatient diabetes specialist nurse in the past, and that, you know, that sort of missed opportunity almost, or sort of, and knowing that you make a recommendation, but you don't necessarily know whether that recommendation is then followed up afterwards, because as an inpatient nurse, you're not generally going to see that patient again. But I think you probably need to pick your patients wisely, depending on, you know, what they've been in with and how unwell they've been at the time.
Phil?
Yeah. So I think I personally always started GLP-1s and SGLT2s in hospital, and because I think there's an opportune moment to explain, counsel, discuss, get buy-in from the patient. And actually, I think our team are quite good at getting the patient to understand the reasons why they're taking it, and I'm quite happy then that they'll understand and probably, hopefully, stay on the medicine longer because we've started to explain the reasons why. A lot of the time when we catch someone, say, who's had an NSTEMI and they've come in and just been diagnosed with diabetes, you know, that is the time for us to start maybe dual therapy at that point. Or, you know, you find out that they haven't had necessarily the best control of their diabetes over the last couple of years, and again, it's an opportune moment sometimes when they're they're well enough to get towards discharge, to get them started on each of those therapies. And GLP-1s are really safe in unwell patients. We know if they're not eating and drinking, you can take GLP-1s during Ramadan, have no kind of ill effects from it. So as long as it doesn't stave someone's appetite, stop them from eating when you do want them to start eating again, so post-surgery a little bit too early, then I think they're fine. And for SGLT2s, again, I think it's, as Ines and Vicky both kind of highlighted, it depends on the context, depends on the group of patients. Certainly for the heart failure group, I absolutely think that we should be starting them before the patient leaves hospital, because actually they can be followed up by our heart failure nurse in the community within 2 weeks, as they would do for any change in their diuretic or heart failure medications when they come in. It also means I can counsel them properly when they're in and make sure they go sick day rules. And actually, we know from the EMPA-REG data across a population, if you know across a whole population of patients you're starting on, a heart failure medicine, not on EMPA-REG, but it is EMPA-REG actually, the post-hoc analysis, then actually you can see that, the groups separated really early on. So within 28 days, I think it's 17 days. So across a whole population, if you're starting lots of patients on SGLT2 for heart failure, some of those will benefit that winter. So, it's the sort of thing where you want to get it started. I think the other bit at the moment is that, as we've seen on the news today across the whole of the UK and all the local news, it's really hard to get an appointment with a GP at the moment. Really hard. So, appointments, requests are up 25% at the moment. So, suggesting it on a discharge summary for GPs to pick up at a later date is just asking for things to go wrong and it forgotten about. So my preference is to start them in hospital in the right patient.
I definitely see that from the community side. It's like when you guys hand them over to us, or and they've got an SGLT2 but they're waiting 2-3 weeks, and still to just get it from the GP, because GPs just don't have time to do the letters and prescriptions and things. Andrea, what are you gonna say?
Yeah, so just completely agree and mirror what the others have said. And I guess the other thing I just wanted to add is, I think for me personally, one of the things that kind of held me back were obviously the risk of ketones. But I know as more evidence comes out that actually, although we are still concerned, the risk versus benefit, the balance is very much changing. But what I would also be worried about is starting this on an inpatient. If they didn't have well-established diabetes, I would have been thinking, am I starting someone on a diabetes therapy when actually they could have gone home and been able to manage with sort of lifestyle modifications? So that really what the ADA has done for me now is really made me change the way I'm thinking and really think about why is that SGLT2 being started, especially in those with heart failure, and really thinking about the studies that I think are coming. I don't know if there are any already, and some of the others might be able to add, but there certainly will be studies coming out looking at the benefit of those who don't have diabetes. So actually, this changes my mind on this a little bit. If it's indicated for someone in heart failure who doesn't even have diabetes, then any risks I had about them not leading a long-term diabetes therapy if they've got heart failure kind of gets blown out the window, because it'd be for their heart failure. So it's just opened my mind to think about the indication for starting the drug really as well, and as that changes moving forward.
That's like that never-ending argument: whose drug is it? Is it a diabetes drug or is it a heart failure drug, isn't it? And the guys were talking about that a lot of the weekend, so that's cool. Okay, should we move on to something different? I know, what should we talk about? I mean, I'm quite excited about the EASD type 1 consensus document. I know Phil works with Professor Richard Holt, as do I, and so I know that he's had quite a lot to do with it. And he was asking, I saw bits and pieces. I think Ines, bless her, was tweeting so much and excellently that I was following you as fast as I could. But I think the top stuff for me, I don't know, did you see it, Phil? I don't know if there's any top lines of like things from that. I think the biggest one that I saw was that they want testing, antibody testing, and in all newly diagnosed type 1, which was a bit like, I think more services are definitely moving towards that, but it hasn't been widely done. So
I think it's getting a firm diagnosis, and the accessibility to antibody testing is so much better nowadays, and it also allows us to kind of catch the MODY patients a lot earlier if you're screening properly at the start for it. So what they suggested, which we've already put into place in Southampton, because as you mentioned, we work with Richard, so it was useful to know what was coming before it came.
Yeah.
So, but they've suggested in all patients getting your antibodies done, just because it allows you to diagnose purely type 1 and rule out maybe the type 3 patients, or certainly younger type 2s at that stage. And also C-peptide, which a lot of us do, is unreliable at diagnosis in reality in a lot of patients. And, it's only those that present late that you'll see it as low generally. Yeah. If you're catching patients early when actually you're looking for the 4Ts, their C-peptide, hopefully at that stage, shouldn't be nothing. Yeah. It talks about cascade testing, because your GAD antibodies cover about just over 75% of most of the type 1 cases. So what they suggested doing from an economic basis is that you would initially do GAD testing, and if that comes back as negative, you would then cascade and then go on to do your IA2 and zinc antibody testing. So that allows you to capture most of it with a single test, which is relatively cheap to do, and most areas will do that in-house. Mm-hmm. And then for us, what we're doing then is we're sending the triple antibody then off to Exeter, because value pound for pound, it's just as expensive for us to do it here as it is to pass it on to them. So why not pass it on to them and get a quicker turnaround time? So we cascade and move to Exeter now for our triple antibody assay. So and the C-peptide, although it's given specific cutoffs that we use in Exeter's data, so the idea between less than 160 to 200, and above 200 to 400, and above 600 at the top end, but that's not lab specific. So I think if you're looking at those, just make sure you've checked with your individual lab what assay they use for the C-peptide. So ours equivalent for 200 cut off with the Exeter assay is 136 in our lab. So I know that we're looking for a much lower number for C-peptide to show complete deficiency. So I think just a practical point, always check with your lab what their individual cutoffs are in relation to Exeter's assay and their data, because otherwise you're looking at the wrong numbers.
So when you get like the lab results and they've got those ranges, is that how you would check that, or do you physically have to ring someone up and?
Yeah, so hopefully most of the labs should have written the ranges on there. Some don't.
Okay.
And so that's why if it doesn't say the ranges on there that are specific to your lab, I think it's always worth going and asking your clinical lead to ask the lab specifically, have they actually checked their assay? Because a lot of the time they'll just use the assay and take the numbers that have come, default from wherever they bought the assay from. Yeah. So most good labs would have checked it and confirmed what their numbers are in comparison to another lab.
So almost like calibrating it, I suppose.
It's exactly that. Yeah, it's exactly that. So it's always worthwhile just checking that, because I was surprised when I asked that question to find out that ours were a lot lower without it necessarily saying so on the screen.
Yeah.
The other thing that I think that the biggest change to me, because it is a massive document, it's worth having a look at. It's a really comprehensive, beautiful type 1 document actually. Is right at the start of diagnosis, mental health is straight in there. Like, it is number one. Consider the person's mental health before you even talk about glucose testing or insulin starts or anything else. Right at the forefront, it says, think about this person's mental health. What support are they going to need? And I think that is a game changer. It's part of the main guidance now, which is really good, not just an afterthought.
Yeah, no, I agree. And Richard's very keen on mental health and that kind of support in his clinical work. So that's good to see that. I think, when do we expect the NICE guidelines to be rewritten for type 1? I know they're doing the type 2 at the moment, and a type 1 to be fairly soon after, or?
So both of them are in progress at the moment.
Oh, okay. I didn't know.
Yeah, so both are in progress, and they'll be out for review, and then it'll be 6 months later after that, after the reviews have taken place, that they get released. So we're probably at least a year away at the moment still.
Yeah, we were having a chat about that the other day, weren't we? Thinking because we're hoping the type 1 consensus might be out maybe October, I guess, for EASD this year, do we think? Or hopefully.
Yeah, so the drafters only had a comment thing, only had comments available for about 3 weeks actually. So it's already closed for comments in the first draft. So it'll be out because it's a consensus document. It gets updated every year.
Yeah.
So the idea is now that ADA in all of its documents will try to update its consensus statements each year, which means that you can add smaller updates all the time if there's something that's been missed. It's always quite useful, I think.
Yeah, and they're always pretty easy to read, I find, for nurses and stuff, or any healthcare professional reading them. The algorithms they do and stuff are really lovely. Vicky, you got a question?
Yeah, Phil, there's just a question that's come in from Facebook about the EASD type 1 guideline you were talking about. Just where can that be accessed? Oh, you're on mute.
Oh, you're on mute. Oh, Phil, you're on mute.
I'll try to post the actual link on here in a second, but if you're to Google type 1 diabetes ADA consensus report, you'll be able to find the draft online. But I can send the link on the chat in a second. You can have a look at it.
I think we posted it in the forum.
Oh, there you go.
I might be able to try and get the link and stuff whilst chatting. Andrea's got a question whilst I try and find the link.
Yeah, so you mentioned, Phil, that these things go out for comments and that the nice ones are under sort of review at the moment. How do people access or get the ability to make these comments? What should we be looking out for when they ask for us to contribute towards these documents?
Yeah, so the first thing is register as a stakeholder. So all organisations will be asked if they want to be a stakeholder. If not, you can just register as a stakeholder on the NICE website. So the first thing to do is go and find out the ones that are in progress, register as a stakeholder, and then when it's released, they'll send it to you for comment and they'll let you know. And then after that, so all the organisations get invited as well. So if you're part of DSN and you probably want to comment as part as an organisation, or the same as Trend or UK CPA for us as pharmacists, Royal Pharmaceutical Society, the NMC, so the Nurse and Midwifery Council, Royal College of Nursing will probably be a contributor as well. So there's lots of opportunities, but each individual hospital or trust or CCG or PCN also can register as a stakeholder and comment. So it's quite important to do so, because they do, having been part of a guideline in the past, all of the comments will be reviewed and grouped together, so by the team, and then they'll pick out the pertinent ones and it's put to the panel to review. So it doesn't go to nowhere, essentially.
Any feeling for how many nurses, midwives or allied healthcare professionals register as stakeholders, or do we need to step up, or is there plenty of comments already?
It's always worth stepping up, because I think that the more representation you can give from your profession, also give a slightly different stance on things, is good. Because generally speaking, you'll find the bigger hospitals are registered, and you'll find all the massive organisations are registered in the patient groups. So obviously Diabetes UK, JDRF will all be registered, and they probably make the most comments because they'll have a collected massive list of comments that they put together. But it's still worthwhile registering as a stakeholder, because they all do get taken into account. It's not, they don't get ignored.
Yeah, it's one of those things, you've got to be in it to win it, I guess. You can't
Absolutely.
complain if you haven't had a thing. I've put the link in the Facebook chat to the consensus document, so people can have a little look over that. And it's got a really nice little video on that explains it and stuff from Professor Holt, so that's quite a nice little thing to read. So Ines, I know you were very excited to talk about this thing that you were watching from Kamlesh Kunti about clinical inertia and deprescribing, which sounds like one of your special areas. What were you seeing about this?
Yeah, so it was another fantastic session. So he actually presented something similar to at the latest EASD. So, and he's got very good data, not only in the UK, but actually global data, which is very, very cool. So it's around therapeutic inertia, and what does that really mean? So it could be like, it's quite a broader, complex concept, okay? And he kind of explained it very, very, very easily. It's literally like the failure to intensify and de-intensify treatments, okay? So we've got both sides here in this concept. So it's actually quite interesting, because we all know that a treatment intensification takes a long time, and you could see he had quite a lot of good graphics. You could see that it is global, so it was shared between countries, okay, even in Europe or in America. Actually, we take over 6 years to put a patient on triple therapy, okay, patients with very high HbA1cs, and insulin. He was given a rough approximately 3.7 years to intensify treatment to insulin. So we're actually talking about big numbers, right? Because throughout that period, the patient, and he has mentioned this glycemic legacy. So if we actually don't act as soon as possible, the patient will suffer multiple complications, in particular microvascular complications due to that hyperglycemia. Also, we also got the other side of the coin. So how to de-intensify treatments in those patients. And this was more focused on elderly, frail cohort of patients. So quite interesting how to relax glycemic targets and actually simplify the regimen. And that fear that sometimes healthcare professionals have, I'm not sure about stopping this insulin. What if the HbA1c goes up? So quite an interesting discussion. Lots of food for thought, especially for primary care. I would say pharmacists, nurses, very, very interesting.
Yeah, it's definitely a big issue, I think, in primary care that we see, isn't it? And even I had someone just yesterday referred with a HbA1c of 35 and they still got them on insulin. It's like, what? So we're doing a lot of that, but I don't know what the answers are really, apart from, we do so much education and things, but it's just everyone's just struggling for time at the moment, aren't they? I'm wondering if Isaiah, you said it was oral therapies as well, and I was thinking, is it just the insulin side of things, because people are just petrified of insulin in my view, experience, I think. So it's it's an ongoing issue, is it? Andrea, what were you gonna?
Yeah, it's actually just going to mirror what you were just touching on. So I put my hand up a bit prematurely. But we do get it, I think, in the inpatient setting as well. When you look at sometimes things like simple dose titrations when someone has developed an AKI, or, someone's persistently hyperglycemic and they don't think just to bump up the insulin a little bit. And I know that there have been studies out there that saying actually it comes down to confidence and sometimes fear. And that could be fear of making a mistake, but also fear of repercussion. I think in some ways it's fantastic that we have inpatient specialists or DSNs in the community and diabetes specialist teams around. But I think sometimes maybe one of the drawbacks is then that and I don't know anybody that's judgmental, but there's that fear of is the diabetes specialist going to come along and go, why did you do that? It's safer and easier just to hand it over.
Yeah, or it's that kind of we're doing so much of it that they're not being skilled in that, I suppose, because we come along and do a lot of it for people. It's difficult. Tamsin?
Yeah, I think the same thing. I think as well, I mean, not that I'm trying to put myself out of a job or anything, but I think there's a fact that you sort of de-skill people in hospital, because as a team we're very responsive to our referrals and our bleeps and things like that. So we get a referral, we get a bleep, and we're on the ward usually within 24 hours. So nobody actually has to make a decision about diabetes in a sense. We're there at the weekends, and so they don't ever really need to make a decision about diabetes. They can wait for the diabetes team to come and have a look at the patient and make a decision. So I think there's that. And I mean, I know, doctors have said, oh, I've made this change, I hope that was okay. And I was like, yeah, crack on, do it, because, we're a small team and we cover an entire hospital, and we're not always able to see every patient in the hospital. But then on the flip side, we've had one today where one of my colleagues changed the prescription. There was no medical notes, so was unable to document in the medical notes. So documented on a piece of paper, on a separate sheet, that's gone missing. And the doctors have then gone back and changed the prescription back to the previous dose, even though she's a nurse prescriber and it was on the front. She'd signed the prescription and everything. And the doctor was absolutely mortified. When we went up there, she was like, I'm so sorry, I should never have done it. I don't know why I did it. But she actually changed it back to the previous dose. And the lady's running high, and you just think, so you've got the flip side, haven't you, that somebody that they're terrified of changing things, and then on the flip side they change things and not in necessarily the right way. But I think there is that, in the sense that we are there and we're very accessible, and I'm assuming that most of the hospitals are the same and things like that. So
Yeah. Andrea?
Yeah, so that it just makes me think of another session that I guess is kind of related. What a lot of the systems in America seem to be using is automated prescribing. So they're using algorithms built within their electronic systems. Now, for example, where I work, we have an entirely electronic system, which is actually the same system as used by many of the hospitals in America. So of course you can imagine I saw these and
Yeah,
went,
you were like,
oh, how exciting. I can just get that put into our system and like we can just go and do the really exciting stuff, and all the basic titration can be done by an algorithm. So on the face of it, it seems very exciting. But actually hearing this conversation again, I guess something we need to look into is actually would that worsen inertia? So people become so reliant on an algorithm, a bit like if, say, someone's on a closed loop system and I don't know if they fail, but if it failed, or you have someone on a pump and they have to go back to the subcut pens, and it's a bit like, oh. So it just made me think of that.
Yeah. Vicky?
Yeah, just coming from the community perspective. So my previous job was sort of working alongside practice nurses and sort of upskilling them and seeing people jointly, so that obviously I could impart my knowledge, but they could obviously then develop their own knowledge. And what we found when obviously COVID hit and we had to come out of primary care to continue our community clinics, a lot of our practice nurses over time, sort of, it's been a year or more, hasn't it? A lot of them have said that they feel that they've lost that confidence because they haven't had that contact with us. Although we were there at the end of the phone to give advice. They used to really look forward to those clinics, and because you're getting more and more complex people certainly with type 2 diabetes being looked after in the community, they really welcomed that support and peer support really to help them develop.
Yeah, I think we found the same, because we knew that primary care was so busy, and also then they took the vaccine program on, and so we were doing a lot of work for primary care in our team, and we've had the same now we're trying to push it back into the primary care a little bit more. But again, we found the same, either the nurses have left, the skills there that they had are gone, and it seems like we've gone back to a completely different sort of area across the Southampton, really, skills wise. So yeah, that's great. Did you want to say anything, Phil?
Yes, I think it's just there's a for those that kind of want to know more information, obviously Kamlesh Kunti has been talking about therapeutic inertia for a long time, and has had UK data because of our databases for a very long time. What's been useful to see now is that you get the same in America and other healthcare sectors, where you have private healthcare as well, and you still get therapeutic inertia in private healthcare, and which I find fascinating. So in terms of the if you go onto the ADA website again, or Google overcoming therapeutic inertia, so they've actually just finally launched the ADA a new kind of a platform to try and overcome the idea of therapeutic inertia through a number of different mechanisms, and they've given lots of resources to both primary care and secondary care teams to try and work through QI projects, generating new research, as well as empowering, forming collaborations, and, as you mentioned, educating those about why you're suggesting what you're doing. So I think there's, it ends up being a very kind of multifaceted approach you need to take to these things. It's certainly not simple to fix, but if you all start to play a part, if you're interested in changing it, then you can definitely make a difference. But it just takes a lot of people to do it, I think.
Yeah, I think everyone needs a bit of headspace at the moment and time to kind of get used to a new way of working from COVID and stuff. And just certainly, I think in primary care, we can put on so much education, but people just don't have time or headspace at the moment to come to things like long study days and stuff. So little webinars and stuff we can do are great, aren't they, for people? Did you really want to just cover InPens, Andrea? Because you were very excited about these. I'm excited to hear about these. We've got about 5 minutes maybe to talk about them.
Ironically, there's nothing really that exciting. It was more just something I observed from watching the presentation that I thought was worth sharing.
You have to explain first of all what is an InPen, because maybe some of the people watching might not even know what one is. Yeah,
I had to Google it. So I watched the presentation and then went away and had a Google. So it's Medtronic's version of an InPen, and you can fit in Nova log, Humalog, or I think it is Fiasp, into this cartridge device. And it is a clever device. It connects via Bluetooth to an app. And then in that app, you can have things like a bolus calculator. It monitors the temperature of the insulin. It will look at what doses were given and when. It can give reminders and various different things. Actually, it does seem in principle like a really good idea. Particularly, you know, it almost brings some of the technology that can be useful in pump therapy in terms of reports and such into someone who's using MDI. So, and as I was watching it, they were kind of building it, and I was getting really excited about it. I thought, oh wow, this is going to be really good results. And they suggested that there was a statistically significant result. And the primary things they were looking at, they split their group down, and we're talking about numbers in the hundreds, people predominantly with type 1 diabetes, looking at adolescents with an average age of about 11 and adults. And they split them into those that had a GMI, so they couldn't do HbA1c, but they used GMI from CGM data of those of over 8% and those of over 9.5%. So this was in those that already had sort of not ideally controlled glucose levels. And what they did is they introduced the InPen along with its app. They did not mention or talk about what education was provided alongside that. And I think that's something to take note of for later. And what they said is that their primary outcomes were time in range and also looking at hypoglycemia. What was quite interesting, and carbohydrate hypo treatments. So what was really interesting is they said there was a significant increase in time in range, but that significant increase was an hour and 20 minutes a day. So for me, it was just a really an eye-opener and a reminder to sort of think, when I see a significant p-value, because it had a p-value of 0.05, to always look at the actual numbers that go alongside it as well, because others may well disagree, but I'm not sure that an improvement of time in range for an hour and 20 minutes a day is clinically significant. But I could stand to be corrected. And I think that's why I want to talk about it.
That an hour and 20 minutes a day probably is quite a lot. I don't know. What do you guys think? Because I just think, if you're thinking of the 1% on CGM data of like hypo, that's 15 minutes a day, is it? Am I right? Yeah. So 4% equivalents to an hour, if my maths is round off my head, a day. Phil's gonna definitely help.
Come on, Phil,
right.
help us out.
No, you're spot on. I think it depends on where that time out of range was, doesn't it? I mean, if it's all in the hyper range, it makes a massive difference. If it's all just slightly above 10, it makes not that much difference. So I think it depends on the person. But yeah, interesting though.
Is that, I mean, because Phil and we've been using like the NovaPen 6 down here as like a pilot site, and I've been having a little play with it and trying to get used to it with some of my patients. We've got a few people on it. I'm not quite sure at the moment. Are you seeing, like, it's great to be able to see the data and stuff, but I'm not seeing it at the moment because it's not connected to CGM, is it? It's a bit clunky.
I think when all the background systems work, because the idea is that the data will work in LibreView, so that you'll be able to bring up your LibreView with your bolus dosing timings on the same graph, so it'll look like you get with your pump data. Basically, you'll get exactly the same. So interpretation in clinic, you know, if you've got time to do it, is much better with the connected devices, and it is quite neat. I think what the question is at the moment is how else can it be utilised, and so we've been tasked in Novo as part of this pilot to try and create some background software to maybe allow district nurses to have some clinical oversight over the doses. So say, for example, you have a number of nursing homes that have connected devices for basal insulin maybe, and supervised administration. That district nurse could maybe have those carers, and they could just look at a screen and go, I can see that all 8 doses were given today on time, you know. And that sort of background software to this technology has the potential to change practice quite a lot. We're just not there yet with it.
Yeah, I agree. Yeah, go for it, Andrea.
It does the out of interest, because again, this is then I was thinking I need to look into the NovaPen 6, so it's good that you guys are here. Does that come with any kind of associated app like the InPen does? Because the InPen's not available in the UK. That was the other thing I was going to mention.
So at the moment, we're patients having DSN as an app on their phone, and then they're having to literally touch the pen to their phone with the app open, and it downloads the data. So we need to have DSN open our end, and then it all connects like LibreView and stuff would. But yeah, it's not.
So there's no bolus calculator included in there or anything else.
I don't think so, is that, Phil? I haven't seen anything like that at the moment. I suppose they could input. Oh, you're on mute.
So not at the moment, I think, but obviously Gluco are intending to move that way and move into that kind of that medical device area as well as have the app. So I think there's they have the intention to go that way. The slight difficulty is with all things is that we struggle to get those sort of apps and bits and pieces and bolus calculators that are digital licensed in pediatrics a lot of the time. So I think it has the potential to be great as long as it's licensed properly in peds and you can get kind of coverage for it.
Yeah, and I think the part as well that we're from quite some areas of Southampton are quite deprived, and not everybody has all the tech and stuff to be able to use it. And I know Vicky said similar things, have they? What's
fascinating, the original study about 4 years ago I saw at ADA when they presented the original kind of Bluetooth smart pens, and the pilot studies in pediatrics there, where they essentially tried it in patients that were maybe less compliant with their insulin doses. It turns out that it looked like they were doing better with their insulin doses because they were aware they were being watched, but actually what the kids were just doing is squirting the insulin into thin air. So you can't kind of fight against non-compliance, essentially. Some people just don't want to take their insulin.
There's always a trick.
Is there a that it's a new thing, so it's novel, a little bit like when you gave people the Libra, they scanned like 27 times a day or whatever, and then you look at them now and they're scanning 6 times a day, which is still fine because you're still getting all the data you kind of need, but there's it's less novel, isn't it? And it's the same, I think, probably with any technology potentially that you give anybody that maybe isn't wanting to have diabetes and doesn't want to manage it, is that you're going to have that brief period where they maybe use it, and but is long term, is it actually feasible that they're going to still carry on doing it long term?
I think NovaPen 6 is just going to overtake. I think once they bring it through, that'll just be what people are given anyway, won't it? So it'll just become one of those things. But I think
and obviously we're within 12 months of Lilly's pen, and Sanofi probably not that far behind. But so I think that the tech will be with us quite shortly.
Yeah. So we all need to.
Glad to see there's some tech in that realm. I think it's good that there's some more tech for the people using MDI.
Yeah, and exactly. A lot of it's for pumps and stuff, isn't it? So it's nice to see that everyone's getting a little piece of the pie, hopefully, eventually. But I think it's probably about perfect time to finish. But thank you so much to everyone for joining us tonight. It's been really helpful. And this will be recorded, so we'll get it up onto our YouTube page. I don't think we've had any more questions. So yeah, that's it. So thank you guys.
Bye everybody.
See you.
Bye.